Thank you, Cyprian. It's always a pleasure. So I'm going to start sharing my screen, and let me begin by thanking Pallium India for inviting me again to speak on this. I think I've spoken on this some time ago, but this is one of my favorite topics, so I'm more than happy to take it again. Right. So I'm going to be speaking about advanced care planning, and it is also about death and dying. I mean, putting it all together. And this, in a sense, is a talk that is meant for citizens, for the general people, not just for professionals. It's if you at any stage find it anything that you find a little difficult to understand, please feel free to interrupt, and we can. I'll try and answer it then and there. Through this meeting, I think the chat box will be open, so please keep putting up your questions there rather than leaving it till the last minute. So let's just look at how the world, I'm talking about India, I'm talking about the world, deal with death and dying. So the one part of the story begins in the 1950s to 60s with a remarkable person by the name of Dame Cicely Saunders, who actually passed away in 2005. She first trained as a medical social worker, then she transitioned, she trained as a nurse. And when she was working as a nurse, she had to deal with cancer patients, and she realized that morphine was grossly underutilized. And she began to start using morphine in small doses and gradually picked up. And eventually, this was the basis of her doctoral thesis on the use of morphine for cancer pain. And she built up a huge body of evidence. But she was told that nobody would accept this learning from her until she became a doctor. So at that age, she actually went ahead and qualified as a doctor. And effectively, she started the field of palliative care. There's a photo taken much later. In addition to the physical pain of cancer, her insight also led to understanding what is called as total pain. That the physical, the psychological, the social, the spiritual, all intermingle. And when somebody complains of pain in one part of the body, it may be any of these other three or all of them together. And in a sense, she was a true Gandhian. One of the quotes on the website actually says, if one man from a poor village in India dies without pain because of what I have done, it will all have been worthwhile. Now, she was working in the United Kingdom, and her work focused on cancer-related suffering. You've also got to remember that the United Kingdom had universal healthcare, which means healthcare completely taken care of by the government, which is still so today. People, of course, find it perhaps not as superbly efficient as earlier, but it is a system which the average UK citizen trusts. Anyway, that's a little different part of the story to let you know that by the 1990s, it became obvious that the kind of skill sets that palliative care physicians had, it was important to apply the same to non-cancer deaths. And we know now that palliative care is applicable to all serious health-related suffering, especially to end-of-life care. What is end-of-life care? It is when we think that somebody has about 6 months or 1 year, at least definitely less than 1 year, perhaps less than 6 months to live. And the 6-month figure is important, for instance, in the United States, because if a doctor certifies that somebody has less than 6 months, then it is the government's business to make sure that they get care wherever they require, and that is called hospice care. Hospice also means a location, an institution which provides care, but in the US, typically it means the overall system of care, and obviously it's mainly palliative care. We call an individual having terminal illness when the time is as short as weeks to months, and when curative treatments can actually be given up. And then as time goes down, uh, you eventually reach a stage where the person is actively dying, and physiological parameters start to deteriorate, blood pressure goes down, urine goes down, and so on. And we have to manage all the suffering that comes with it. Now, remember what I told you, that the United Kingdom, palliative care, cancer-related suffering, completely a government-run activity. In the USA, around about the same time, medical progress, especially from the 1960s onwards, really became pretty technological. So intensive care made it certain that, or at least highly likely, that you could go into hospital seriously and actually survive. Remember that before the 1950s, before antibiotics, if you had a serious illness, literally it was, the Hindi term for it is Ram Bharose. You don't know whether you would come out or not. Organ transplants started about that time. And what happened is that death became medicalized. So before that, people used to pass away at home, but now it became more and more likely that death would occur in the hospital. And together with that, remember that human rights were sweeping across the world, the idea that we were all equal, and that spelt the end of medical paternalism. The idea that doctor knows best, no, that disappeared. Remember that even earlier than that, it was understood that you could not do anything to a patient without their consent. So if you take these two concepts, human rights and informed consent together, you can understand how this comes together. And in fact, it was a human rights lawyer in Chicago who proposed this idea that patients should take charge of their own last days and simultaneously make an agreement, a document, which would save doctors from litigation if they did follow their patients' wishes. And this became a movement through the 1970s with various individual American states taking it up with living will laws. And finally, the United States federal government, the central government, passed what is called the Patient Self-Determination Act, which makes the every hospital that has any central government funds makes it necessary for the staff of that hospital to ask every patient if they have an advanced medical directive and if they want to make one. A little later, it became obvious that the living wills needed to be accompanied by what is called a healthcare proxy appointment. And I'll explain that a little further, because very often towards the end of life, multiple things happen. It's not enough to have just a document, because it can't cover all eventualities. So you need a live person there to interact with the doctors to help make decisions. So that's why a healthcare proxy. And the combined document is called the advanced medical directive. But obviously, it's not just about documents, it's also about a conversation. And that conversation with friends, family, healthcare professionals, everyone, is now termed advanced care planning. So if you look at it in that sense, the term advanced care planning is an umbrella term. We've talked about advanced directives, we talked about the living will, we've talked about the healthcare power of attorney, but it is also what are termed do not attempt resuscitation orders, or do not intubate, which means orders saying that this individual does not want to be put on the ventilator, or combining everything together in what are termed as physician's orders for life-sustaining treatment. So when somebody is literally at the end, unless a doctor or a paramedical person knows in writing that this patient has asked for such and such thing, it's not easy for them to follow it, because a living will can be somewhat, as you'll see, a somewhat complex document. So it has to be translated into these orders. And never forget organ donor registration. Even that is a form of advanced care planning, but by younger people. So how, for instance, does say something like the do not attempt resuscitation order work? So let me tell you this story. Some 20 years ago, a friend of mine was a senior resident in London. And one evening, a patient of his had a cardiac arrest. If you've seen the defibrillator, it actually gives a huge shock. The patient's body jerks, which was what happened, and the heart restarted. But it happened again and then again. But finally, it all settled down with medication and so on. And in an hour, the patient was fully conscious. And he asked for the doctor on duty. My friend went there. The patient held his hand and said, "Don't do that to me again. Let me go in peace." And my friend could only just nod. So obviously, the discussions went further, and the patient was moved out of the ICU, and then he passed away. So this is a way in which people can take charge even towards them, but that's not always possible. So when we talk of taking charge, probably the most important single decision that can be made is uh, where to pass one's last days. Now, if you look at it, this is a fairly large survey from multiple countries. If you had a choice, where would you prefer to die? This light blue is at home, right? And it's big, it's the biggest. The majority of people want to pass away at home. But where do you think you're most likely to die? Well, more and more people think, no, it will probably happen in hospital. And in fact, um, if asked, where did your relatives die? Most of them say it was hospital. So 90% of us want to die at home in our own bed. And this is a figure that my friend, a palliative care physician, Dr. Priya Kulkarni in Pune, actually did a survey in the general public in Pune. More than 3,000 people answered, and 88% of them said, at home in my own bed. But in reality, 70 to 80% will die in hospital. So you'll wonder, is it possible to pass away comfortably at home? Well, these are the two senior Bushes, George Bush, the first president, and his wife. And they actually passed away at home, literally in Darbar, surrounded by the whole family. In all developed countries, this is fully financed by the government, almost in every country. In fact, in the USA, as this information spreads, not just presidents and VIPs, more and more regular people are also passing their last days at home. So, what is it that happens? It's not that people don't become seriously ill. They do become seriously ill. They do go into the ICU, but they are discharged home after hospitalization in the last 30 days of life. So, even though they go into the ICU, they are discharged, moved home, and allowed to, help to pass their last days in their own beds. Is it possible to do this at home in India? Yes, it is, but not all over India. There's only one part of India where hospice for palliative care at home is the norm, and that is rural Kerala. Part of it is because in rural Kerala, it is the community's responsibility. This was some time ago, and I was following my friend on rounds, on his home care rounds, and this was a picture that really struck me. Palliative care in that village, in those communities, is actually supported by the community, and not just by cash, but also as volunteers. That's not something that is easy to achieve elsewhere. Now, if this kind of decision making is done right, if people take part in their own decision making towards the end of life, it actually reduces healthcare costs. And this has been shown in this paper But if you're looking at it purely as an economic thing, what about if you look at it as an emotional thing, which I think is actually more important? And a trial actually showed that patient and family satisfaction, when as regards quality of death, was much better when uh, patient and family had control over the last days through advanced care planning. So you can understand that making it effective actually does depend on conversations. And these conversations are not just between healthcare professionals and the patients, it's also between patients and families, healthcare professionals and families, everybody. It's important to start this conversation today. You can look up the conversation project in case you are feeling inhibited about how to talk about this in your own family. This is very, very useful. The English is very simple, so you can easily convert it into any local language and use it. So, again, to reiterate, uh, the process that I'm talking of, advanced care planning, is basically death literacy. It's at the end of life, a process to guide decision making about your healthcare if and when. In fact, as I'll come to a little later, it's quite invariable when you do not have the capacity to decide for yourself or to communicate your decision. Unfortunately, India is not a country to die in. And let me take you through why I'm saying that. So in 2010, a team, this was actually by the economist for Singapore Foundation, they put together this document, and you can read this. It is available free on the net, 2010, 2015. They looked at what they termed quality of death. And this has to do with the kind of care that people get at the end of life, the kind of palliative care that is available. In 2010, uh, looking only at end of life care, India was the last of about 40 large countries. In 2015, our position had improved somewhat because they had found more countries that were worse than us. And fortunately, I think both China and Pakistan were worse than us. This survey was repeated in 2021, and they looked at more parameters. And again, our relative position, we were just above the last grade, was, well, it's still not anything to be proud of, right? So, what does it take to die well? The first is knowledge, to know when death is coming and to understand what can be expected, to have time to say goodbye, and also to be able to leave when it is time to go and not prolong it pointlessly. Then you need control, you need dignity, and you need privacy. All of this you can do with advanced directives. And most importantly, choice and control over where death occurs and in whose presence. This dying should be with pain and suffering controlled as much as possible. So symptoms have to be controlled. And for that, you need information, you need support, you need hospice care. All those are the things that go to make the dying process peaceful. And in India, the first problem that we have is that these conversations are termed apshakun, bad omens. We should not be talking about death. I think that is rubbish. In Tibetan Buddhism, talking about one's mortality is part, or thinking about one's mortality is a part of daily meditation, and their population is not going down. So I think there's a fair amount of speculation when and how uh, Hinduism developed this massive bar against discussing death, but it's not just Hinduism. Actually, most cultures don't like talking about death, except that modernity and technical advances have made it necessary. And then to have control, dignity, and privacy, you require legislation. You need to put in place rules and laws so that this information can be obtained, so that doctors can have this conversation. Unfortunately, um, India has no legislation whatsoever. And the last, uh, having the capacity, the systems, the capacity to manage this kind of suffering. Again, there too, we are hugely underinvested. There are just 200 palliative care doctors all over India, maybe a little more, and a good number of them are in Kerala. So the rest of the country is not well served at all. But for all of us who need to understand how this is so and what can be done about it, the first point to start is to understand how we die. I call these the 5 roads to death. And it's when you look at these 5 roads that you begin to understand how long the journey can take. So, all of us imagine that we are going to die suddenly, go to sleep one night, and wake up the next morning in heaven. Um, Unfortunately, after the age of 50 years, less than 10% of people die suddenly. Actually, the figure is 7%. Our long-haired president actually uh, had a massive heart attack while he was giving a lecture to students, and within an hour he was gone. But remember, that kind of death takes a huge amount of punya, which he had. I'm not sure that's applicable to all of us. But typically, as we get a little older, as we enter our 60s, probably the commonest cause then becomes cancer. And in cancer causes about 20% of all deaths. And this is Mr. Manohar Parrikar, maybe about a couple of months before he passed away. In cancer, once the second or the third chemotherapy has failed, or multiple, or the cancer has spread all over, it enters what is called the waterfall trajectory, which means that it is the tumor that is now making all medical decisions. There is nothing we can do. And if we have a certain amount of experience and knowledge, then we can actually reasonably well predict when that individual will pass away. What about a little later? In the 70s, typically people who have had long-standing bad diabetes, blood pressure, uh, and other illnesses start developing kidney, heart, lung, liver failure, and this accounts for about 15% of all deaths. This is a former Chief Minister of Maharashtra, Mr. Vilasrao Deshmukh, who in fact was waiting for a liver transplant when he passed away. Now, in people in organ failure, they have what is called the looping trajectory. So they have a crisis, come into hospital, don't come back as well, and they are coming in crisis, recovering but declining, and eventually they pass away in a crisis. So we call this the looping or entry-re-entry trajectory. Unfortunately, nobody speaks to them around over this time and points out what is happening. So people often don't realize that. Then for about 50% of us, those who reach our 80s, we will be hit by what is called the dwindling trajectory. So somebody whose level of functioning is already low keeps on dwindling down until eventually death happens. This is old age, frailty, dementia. And if you remember Atal Bihari Vajpayee, we literally did not hear from him or see him. He had a stroke soon after he lost the 2004 elections, and we only realized it when he passed away in 2018. The fifth trajectory, those 4 are natural trajectories. The fifth trajectory is somewhat artificial. And this is the trajectory of neurocritical illness. So think of it, somebody who has a bad brain injury. In earlier days, would have stopped breathing and would have passed away. Except that we have the intensive care to rescue this kind of individual and bring him back from death. Now, the thing is, if the injury is significant, if it is enough to cause coma, then the likelihood that that person will improve with or without disability is actually pretty small, maybe about 20 to 30% at best. A good proportion will still go on to die, and a small number will remain stuck in between in what is called the persistent vegetative state. So, uh, obviously, one of the more difficult kind of trajectories to consider. The point I need to emphasize here that if you look at these graphs, uh, for the majority of us, death is predictable some weeks, months, maybe years before it actually occurs. And if we are aware of how things are progressing or deteriorating, we can actually start, if not putting down a timetable, at least understanding the range of timings over which these events will occur. There's one more point that I need to make here, and that is the difference between cancer and non-cancer deaths. You remember this graph, the graph of cancer, where once it crosses this inflection point, the slope is fairly clear cut, and you can predict when this individual will pass away. Because this trajectory is defined, uh, if the patient and family know about it, know what is happening, then they can retain control right at the end and avoid unnecessary admissions. The problem with non-oncologic or neurologic deaths is that the trajectory can be both erratic and prolonged. And recurrent admissions may really be unavoidable. In fact, if somebody has dementia, then well before they reach this stage, somewhere around here, they may have lost their personhood, their ability to control their circumstances. So, expensive and avoidable ICU care is more likely with non oncologic or neurologic deaths. Um, there's one more factor to consider, and that is the role of doctors. Now, before the middle of the 20th century, uh, diagnosis, therapeutics, and prognosis were three equally important functions for us. As medical treatments and diagnosis improved in the middle of the last century, the skill of prognosis means telling the patient what lies ahead, that skill declined. And it has been confirmed that whether it's teaching in research or in practice, the ability of doctors to tell you what lies ahead has gone down. And the way I put it is that this job of prognosticating consists of both foreseeing and foretelling. When you foresee, uh, you have to pass on that knowledge to the patient and family with honesty, accurately, and preferably with also a certain amount of optimism. And that's not very easy to do. But unless a doctor picks up the skills and commits to foretelling, um, their foresight also tends to go down. And that's something that I'm little uh, saddened by, but I can understand why it happens. And when a clinician who's aware of all of this communicates with the patient and family about end of life care, these are the three things that we have to talk about. The first are goals of care. So basically, you're combining uh, uh, this with patient education so that over multiple encounters, you, in addition to the discussion about treatments, you also talk about what they hope for uh, in the medium term or maybe even the short term. We've already spoken of advanced care planning. So this kind of information has to be put into documents, make it actionable, and that becomes advanced care planning. And if this is done right, then at the last, you can combine inputs from the patient or family and the clinician and make the most appropriate choices at the moment that they are required. So when we talk of goals of care, what is it that people wish? And these are true of all of medicine, whether you're treating a simple cough and cold or whether you're treating cancer. Uh, we look for longevity, we look for function, and we look for comfort. In less serious illnesses, all three may be addressed. So if somebody gets, say, a minor infection, then treating it with an antibiotic will restore both longevity and function, and it will also reduce pain. But when you come towards the end of life, then it becomes difficult to get all three of them. And it's quite possible that you may have to settle with one or the other, prioritize them, and then focus on achieving at least one of them. And how do different people speak about their goals? There are various ways in which this comes up in conversation. So you pay attention to their values, their wishes, their ideas about their preferences, and often some idea about what they think is their duty. And all of this, with care and a bit of skill, we should be able to incorporate this information in our recommendations to patients. So, when an individual has to plan the last journey, think of it. Think of any trip. Would you like to plan it? Would you want information on travel, stay, etc.? The two classic road trip movies from Bollywood. These guys kind of set off without thinking about where they were going. When I was young, I could do that, but now I need to know uh, about my stay, about my travel, whether there are clean toilets, and so on. So, in a sense, this too is the last journey of your life. The destination is fixed, and it's your choice of deciding what you want your illness experience to be like. Some time ago, there was this newspaper report, I think about 4 or 5 years ago, 2018, sorry, 6 years ago. And this was a couple, the Lavates, who wrote to the president seeking euthanasia. Because, as they said, we don't have children, and we don't know who will take care of us towards the end of life. So what they actually wanted, the president, was to send a helicopter to evacuate them to heaven. That obviously was not a request that was going to be granted. But for many people, making sure that and keeping control of their last days, especially LGBTQ individuals who may be estranged from family, it's extremely important to document this. So if you think of the last journey of your life, you have to understand who has the information, who is planning, and whose responsibility it is to plan. If you think of who has the information, I've already told you that foreseeing and foretelling have always been the doctor's responsibility. Unfortunately, it's not very easy to do, and often many doctors tend to avoid it. And it's also true that within our culture, the attitude that usko mat batao also hampers our communication. People don't understand that honesty really is the best policy, and that when you hide bad news, depression and anxiety actually worsen. So, till we reach the stage that doctors are willing to tell and their patients are willing to hear, I guess it's important to realize that the ball is in your own court, because most doctors' policy is don't ask and don't tell. So, who is planning your last journey? Information we've just spoken about, you have to do it. Planning, well, you can either do the planning yourself or pass it to someone you trust, or if you don't do either, then it is a default mode where nobody plans. Remember that the worst suffering happens when nobody is able or willing to make decisions. And if you really want to minimize suffering and take palliative care, then one or two people have to be in charge. Ideally, if you can speak coherently, you decide, and your choices and decisions will always come first. The problem is, can you decide right till the end? No. We lose decision-making capacity once the dying process begins, which would mean, say, hours to days before the actual day. Now, in cancer, this is uh, roughly maybe around about the same time, or maybe up to a week or two earlier. But if you realize the people who had organ failure, liver, heart, lung, whatever, whenever they cycle down, they lose that capacity. Whenever they are up, they have it. And for somebody who has a neurological problem like dementia, remember that they lose this capacity much earlier, maybe 5, maybe 10 years earlier. And this brings us to the related question of autonomy. Autonomy means that I have the right to determine my own future, to accept or decline any therapy, and to decide also who decides for me. In an absolute sense, it is probably a Western concept because in Asia and India, we prefer what is termed as relational autonomy or swadharma, where your autonomy is exercised with and together with your family, friends, people who are close to you, and so on. So we believe more in relational autonomy, but at the end of it, what matters is the individual himself or herself. So the first decision is I decide versus I decide who decides, or avoid all discussion and take the suffering that comes with it. When people are asked, and this is explored about this I decide versus others decide. In the I decide camp, the first category is an autonomous who takes full responsibility for one's own decisions. And I think I prefer to feel that I am in that category, whether because it is my right to decide for myself. But there are people who take the same decision but do it without, because they don't want to burden other people with that decision making and their suffering. So, uh, effectively, this is an altruist who says, I want to make decisions for them so it won't be difficult for them. What about the others who say, let somebody else decide? Whenever I hold this meeting in not in a virtual sense, I ask the attendees to raise their hands to tell me who would like to take their own decision. And across the board, about 60 to 70% of people want to take their own decisions, but about 30% will not want to. And in this group, you have the authorizers who transfer their authority explicitly or implicitly. Explicit transfer authority is far more convenient for everyone, including the system. But you also do have a small number of people who are avoiders, who actually say, no, I really don't want to know. So you can figure out where you lie in the spectrum. So if you are going to choose people to accept this responsibility and make decisions for you, put them in sequence. First decision maker, second and third. Now remember, these three people are not a committee. They will obviously be talking to each other, but only one person decides. If number one is available, then number one. If number one is not available, then it will be number two. Unless three, depending on the hierarchy, it's the topmost person present who actually has to decide, but it is understood that they'll be talking amongst themselves. So, where are we today in terms of the putting this, whatever we've discussed, into practice? Does anybody want to take a break and ask questions, Sripriya? Hello, Sripriya.
Yes, sir.
Anything in the chat? Any
Nothing
questions?
that I could see. We just had a comment from Shalka that she's loving
Okay,
that
okay.
we are using famous legislators as examples. So,
Okay, no questions. If anybody wants to ask a question, I don't mind taking. Don't need a break. Okay. Wait, I'm going to get myself a glass of water. Question? Hi, somebody wanted to ask a
Yes.
question?
Yes,
sir.
I wanted to ask you. Thank you for,
Shoot.
your presentation so far. I have been, thinking of one thing and just wondering how one achieves that, because I was trying to write out a living will.
Wait, that's coming up.
No, but
We still have
okay, then I'll ask you later, because there's
that's coming up.
there's a conflict I'm seeing, and I wanted to ask you about it.
Okay, let's see if this
Okay.
is sorted out. Otherwise, we'll.
Okay, sure.
Anyway,
Thank you.
so yeah, so I have been actually involved with this topic since 2011. I was on the medical team that examined Aruna Shanbag, and as time went on, there was two realizations that came to me. One was, of course, the fact that I could not help my patients to the last, and there was a point where I had to say, "Ab main kuch nahi kar sakta." And when I began to learn palliative care, I realized that that was one thing that palliative care never ever says. It's the cardinal sin of palliative care to say, "Kuch nahi kar sakta." Of course, you can care, but the other realization was that as an Indian citizen, I had no control over my last days. And obviously, there was other things happening. There were other people involved, interested. And in 2015, the three national medical associations of neurologists, critical care medicine, and palliative care came together to see if we could do something about this. And well, things did happen. Some we could take credit for. Some we were very lucky with. One thing that we were very lucky with was that between 2017 and 2018, multiple cases that had wound their way up in the Supreme Court were decided by constitutional benches. These benches took the liberty of the Constitution of India, which was in a sense a political concept, into our personal space. So you had the privacy judgment, Puttaswamy, health autonomy, which is where we are concerned, and sexual choice. We never think of them as actually a triptych of judgments that came out at around the same time. And you know that they have really changed the way we citizens look on our rights and responsibilities. But for us, the most important is this one. And in 2018, these were the words of the then Chief Justice, Deepak Mishra. He said, all adults with the capacity to consent have the right of self-determination and autonomy. We have the right to refuse specific treatment, even if this decision entails a risk of death, and you can treat somebody in emergency only if it is not practicable to obtain their consent. But where a patient has already made a valid advance directive, which is free from reasonable doubt, and specifying that he or she does not wish to be treated, then such directive has to be given effect to. This is the law of the land. Now, unfortunately, this is a judgment. So judges, it's not their business to make laws which says thou shalt not. So you cannot take this to state that if a doctor does not do this, they will get punished for it. No. Unless people start filing, and in the US, this is a major cause of litigation. This is called wrongful life, where somebody has asked not to be resuscitated and they are forced to end up in an ICU until they finally pass away. So that's called wrongful life. In India, this has not yet happened, but I'm presuming that something like this will happen. But any doctor who says that I will treat, it is my decision, no, it is not her decision or his decision. It is a patient's decision. Unfortunately, in this judgment, they made a judicial functionary, the judicial magistrate first class, the signing authority for everything, for the advanced medical directive, and even for the last stage, where the advanced medical director was actually operated. And it took 5 years. And of course, the pandemic also came in between before we could finally convince the Supreme Court that judicial magistrate first class was a major bar to making anything happen. And once that JMFC was edited out, which happened in January 2023, then things have begun to move. And for anybody who wants to know more about this, I'll show you the websites and you can look this up. So what can you and I do today? The first is to understand when you should or can make advanced medical directives or do the process of advanced care planning. One time to do it is with trigger events. So a new diagnosis, a new major diagnosis. I mean, obviously say something like cancer, yes, but even having a heart attack or anything major, or a hospitalization for a serious illness towards the later years, or when somebody starts to require more and more support, care. Somebody who is able to manage everything themselves now needs somebody to be around them. But actually anytime, because it always seems too soon until it is too late. So effectively anytime. But it's still important to understand about how these documents work through various stages of life. The first are healthy adults or those maybe who have never planned for this kind of thing. So here the identifying a healthcare agent is very important. The next, if somebody has an illness, maybe complications, already has been to hospital, then goals of care. And finally, when somebody is in the last year of life, which is something that we can almost with 80% certainty now say, that's when you need to put something like a DNAR or so on in place. So if you remember the advanced care planning umbrella that I told you about, all these documents, these two are the general ones. These two are the ones that come up. Three are the ones that come up later in life. And organ donor registration can be any healthy young person. Now, if you look at somebody who's young and healthy, would you really think of advanced care plan? So everybody knows these two individuals, Barack Obama and Michael Schumacher. Well, Barack Obama announced in his first presidency, I think it was maybe 3 years into it, that both he and Michelle had made their living wills and advanced medical directives. He was not even 50 at that time. Why would he do that? One reason is because the US president has an occupational hazard of being shot, right? What about Michael Schumacher? He finished his racing career with God knows how many millions, hundreds of millions of dollars. And some years after that, he had a really, really silly skiing accident where he somersaulted and he fell on his head. Bad head injury. This is now almost, I think, about 14 years ago. But this news report was about 2.5 years after the accident. He still could not walk or stand unaided, and we have not heard from him at all. His family is very concerned about his privacy. So generally, there's not too much known, but except to know that he's severely impaired. So for anyone who's concerned about catastrophic brain injury, I have a patient who's 31 years old, and she feels very strongly about organ donation if she's ever seriously brain injured. So her advanced medical directive incorporates organ donation, and well, to my knowledge, she's already updated it twice. What about something where something bad does happen? Now, this was my patient who had a bad brain hemorrhage. This is a CT scan showing a brain hemorrhage. She underwent brain surgery, and in fact, technically she did well, but she was completely paralyzed on the left side. All that she could do was feed herself and could control her urine and motions, but she needed people's help to clean her and dress her and do everything. And she was extremely upset. She kept telling her husband, "Why did you have me operated?" In fact, even a brother who came too late to influence the decision, was upset. And the poor old man had a tough time. In fact, her sister, who was just a little younger with diabetes and hypertension, had an episode of ischemic heart disease. And the first thing she did was, I want to make my living well. And because she said, my husband is, I won't trust him with making the right decision, she put her best friend. And her son has power of attorney. So that's something that people can do. What happens when somebody is near the end of life and you think the survival is 1 year or less? Now, this is another patient who I know. He's 80 years old. He has lung disease to the point that he needs oxygen. But he has promised to attend his granddaughter's wedding a year ahead. So he has actually made a detailed directive which says that if he needs ever to go on the ventilator, then only if it is likely that he'll come out in 3 to 5 days, basically to check for reversibility. If it lasts longer than that, then he should be allowed to go. And if at any stage his heart stops, again, he should be allowed to go. But as far as possible, he'd like to be around for his granddaughter's wedding. So wherever you make the advanced medical directive worldwide, it needs 1 or 2 witnesses. It doesn't even need attestation. Occasionally, it needs a notary public signature. And now that is where we have reached in India. We need 2 witnesses, and it has to be attested. The signature has to be attested either by a gazetted government official or by a notary public. And these are conditions that all of us can manage. But for it to actually work, we all need to talk. We need to talk to our families. We need to talk to our doctors so that our wishes are not just on paper. They are understood and accepted by everybody. Ideally, this document or the other documents like it have to be made in multiple copies, kept in medical records. In the US, the last document, what is called the physician's orders for life-sustaining treatment, is a brightly colored, very clear and crisp document which people actually stick on the fridge door. Because if somebody falls unconscious, that's where the paramedics are supposed to look. And it's important to inform everybody who needs to know. People who are going to make decisions for you, the family doc, and ideally at every procedure, you should take it along. So let's look at the document that we have in India. If you look at the Pallium website, if you just type in Living Will and Pallium India, you will get this. This document, you will find multiple versions on the internet, but this is the one that our team worked on, and it has legal input also. So you can look this up. It says, I am an adult. If the time comes that I can no longer take part in decision making regarding my treatment, this declaration will comprise the final expression of my wishes, and it is requested that all concerned should take these wishes into account. Now, how do you make this decision? If I go into coma with no reasonable expectation of regaining consciousness, or if overall I have a disease state from which I have no reasonable expectation of recovering with an acceptable quality of life, these are discretion statements. So you have to, again, there is something more that we have to do. Or reach a persistent vegetative state with no reasonable expectation of regaining significant cognitive function. So of these, 2 are reasonably clear cut. This one needs discretion. What is needed is that a panel of 3 doctors of the hospital where I'm admitted should confirm this. And if any of these life-sustaining treatments that are listed below, and you're supposed to tick what you do not want. Most people generally would tick off everything. And if there are any other specific wishes, you write them in by hand. For instance, some people write that if I am in a position that in this kind of situation, then I want to be sustained until my son comes back from the US, or things like that, right? Or if there is a 10% chance that I might recover, then I would like that to be taken. So individual wishes can be added here, but this is a broad pattern. Now, the physicians will not be liable for the consequences of my refusal of treatment, right? So remember that the living will is also indemnification of the medical community. That's important. To secure compliance with this declaration or to make medical decisions, because both of these are separate statements. I hereby appoint the following as surrogate decision makers. Now, you could cut this out and say just compliance. So my healthcare power of attorney just has to make sure that my wishes are carried out. Or my healthcare power of attorney can make medical decisions. So you have to understand that these two statements are important. And then you put 3 names down. Ideally, the topmost one. If number 1 is not available, then you go to number 2. If number 2 is not available, then you go to number 6. But if number 1 is available, it is number 1 who will sign. Ideally, since they are all people who would know each other, it is expected that they will discuss amongst themselves. And you can say that also. But the authority will rest in one person only. So it's not a committee. And the last point to note is that this remains in force during my lifetime, unless I revoke it at any time. So the thing that people don't understand is that it is made in writing, but it can be revoked verbally anytime. So if the person is conscious, then the doctor is supposed to ask, this was your living will. Do you want us to follow it? It says, no, finish. Story over. I mean, you go ahead with full treatment, and it's only if you recover and go back and make it again that it becomes applicable. So this is important. Is there anything I've forgotten? Yeah. So this also tells you why this is called the living will, because this becomes effective during life. The estate will becomes effective only after death. That's why this is the living will. So just to reiterate, for every one of us, this is important. If you're worried about catastrophic brain injury and want to donate our organs, but for people who actually have illnesses, we have to open this conversation and challenge and change the notion of apshakun, because unless you do that, we will be stuck in this same rut forever. Just to let you know, this document is available on these following websites. Pallium India has it, the Indian Association of Palliative Care. So you just put down Living Will and any of these organizations' names and you will get it. This document also has, I think, 2 or 3 pages of FAQs, which should answer all your questions. As I said earlier, witnesses have to sign it, and the appropriate authority has to countersign it. And that's it. What if this is not done? Remember that, of course, in cancer, once the cancer picks up speed, then it is the cancer that makes decisions. But in neurological illnesses, in dementia, in even in organ failure, we now have the means to keep the body alive indefinitely. George and Barbara Bush, Barbara in April 18 and George in November 2018, both passed away in their own beds, literally in Darbar. And there are pictures of them. There's a recording of the younger Bush telling his father, I love you, and all that. It was a proper regal send-off. What about our guys? Atal Bihari Vajpayee died in the AIMS ICU after 15 days, including 10 days on what is called extracorporeal membrane oxygenation, which is both his heart and lungs had failed and he was on machines. And Lata Mangeshkar, somebody needs to be muted, yeah. And Lata Mangeshkar was intubated not once, but twice. I mean, those incomparable vocal cords, think of that huge tube going into them. A 90-year-old comes out of COVID. All that she needs is to be made comfortable. If things don't go well, she should be allowed to pass off in peace. No. So my statement made only partly in jest is that if you are an Indian VIP, you are condemned to torture before death. This is my email ID, and I'm happy to take questions right now. But if anybody needs to ask me anything more, I'm open to WhatsApps and emails. Thank you. I'll just close this, and this presentation, at least a PDF version, will be shared with Pallium.
Thank you, sir. Thank you so much. I think we had 2 questions in the chat box.
Okay.
One
I'm
was
closing
from
this.
Kailash. Sir, please guide to address the spiritual pain of patients and caregiver during advanced care planning.
So if you look at, there's a document called 5 Wishes. So it's a standard format that it originated from the US, and on that you will get a fair amount of instructions of how people's spirituality. 5 Wishes, FIVEWISHES. 5 Wishes. You just type in the words, you will get it. It's pretty well known. It's been around for years and years, and you can actually download those. They allow, I mean, they are, for a small fee, you can actually make it online. And you can have your spiritual issues addressed as part of it. Would it address spiritual pain? No, that you actually need a counselor who can take the patient through those last days, the difficult journey at the end. But a document may make sure that your wishes are taken care of. Yes, so what was, let me open the, okay, wait. There are questions. Okay. So somebody said that, Aparna said that some people don't even think about this. That's okay. You have to understand that maybe about 10 to 15% of people will not want to open this topic. Spiritual pain we address. Court? No. There is no need for the court to be involved in implementing the directions. That was what was the scene earlier. That is now over. The Supreme Court order of January 2023 made it very clear that the JMFC will be intimated, but consent is not required. Right. No, this is, as of now, AMDs are only for adults. Young people in their 20s, I think ideally, a palliative care consultation and discussion should help because palliative care physicians know how to address these topics. Then, as of now, palliative care and end-of-life practices in the ICU now, the Indian Society of Critical Care Medicine and the Indian Association of Palliative Care have put together a document with protocols and so on for Indian ICUs. It is up there on the net. You may have read somewhere that the government has notified rules of people who should not be put into ICUs and so on. So we are in the process of implementing these. At the moment, it feels like if someone ends up in the ICU, it will inevitably lead to dying in the hospital. Yes, that is true. But it is your right to insist on palliative care being called in. And if you're the person who is in charge, it is not all, unfortunately, big hospitals have palliative care. As far as I know, Hinduja Hospital and Kokilabhen Ambani are the only hospitals in Bombay which have palliative care physicians on their rolls. If in my AMD express the wish to die at home, but also want to donate my organs, now this is a little tricky. So if somebody has a severe brain injury which is causing brain death, then typically they will be in the ICU because there is a moment, there's a period of time when the brain has completely shut down or gone, but the other organs are still working. And that is a state which you can survive only in the ICU. And organ donation can happen. But if somebody is in a state where dying is happening, but it is not as though it is a clean-cut death, then that you can ask for it to be managed at home. Brain dead definition. So very often people see somebody who is not fully conscious and they loosely use the term brain dead. Brain death is a very, very specific term in which the whole brain has gone. Typically, we confirm that by identifying that the patient cannot even breathe when they're disconnected from the ventilator. And it's only then that we call that brain death. So we take brain death as death. So there are two definitions now of death. One is cardiac death, where the heart has stopped, and brain death, where the brain is destroyed. Either of these two constitutes death. Who's the appropriate authority for what? You are the patient is the appropriate authority for everything. So I think in India, we have to get out of this habit of looking for authorities. It is the patient who has to make these decisions. And unless you want to know whether there is anybody else who has to, the only authority that you need when you're making the advanced medical directive is having the signature verified. That's it. Donating bodies to medical research, yes, of course, that can be. So for instance, I think the 5 wishes document has a column about that. But we haven't added it in our living will because ours was more focused on limiting unnecessary treatment. But that can always be added, that it's part of your wish to what should be done with your body after you have passed on. Who bears the cost of setting up of the panel of 3 doctors? We haven't yet worked out the modalities, but I think if I presume that typically in an intensive care unit, if somebody is admitted in an ICU, it's unusual that only one person is seeing that patient. Typically 2, 3, in any big hospital, you'll see at least 3, 4 doctors are looking after seriously ill patients. So in any case, there are at least 3 doctors involved. And then if there's any other further process, I'm sure we'll obviously have to work out the rules. And these costs will also probably be part of that. But at the moment, we are at this point where 3 doctors can certify. Right. What about? So again, pediatric cancer, yeah. So that is where that often becomes very tough counseling for palliative care. But I understand. I mean, that is one of those very difficult situations. But as I said, the advanced medical directive, advanced care planning, all of that applies only to adults. There is a question mark over what we call people who are, say, in the 15, 16, 17 years of age, where they actually understand what is happening. But again, one does have to go through the parents. Right. Anything else? Someone who's not actively dying or is critical. Yeah, so that's what the advanced medical directive is for. No? So about how to organize one's last days. how to avoid unnecessary treatment, how to make sure that your wishes are carried out. Once somebody is actively dying, then likely the whole everything will end in the next few days. I think I answered that. Where do we get the 3 doctors? Typically, in somebody who's in the hospital or in the ICU, where this withdrawal decision has to be made, typically they are being looked after by more than 1 doctor. And if not, then the primary doctor can always refer to another 2 to support his or her judgment about the situation. Again, I'm not sure if you realize these situations, this living will entirely applies to hospitals. If palliative care is involved and everybody understands that the patient does not want to be admitted, then the story ends and palliative care can manage them at home itself. Any more questions? Right. Who's there from Pallium?
Yes, sir.
Yeah, hi, bolo.
So I think if there are no more questions, I think we can call it a day then.
Thank you,
Right.
doctor. That was really, really very.
Please download that document and look at it.
Sure.
Okay, chalo, bye.
Practicing where you are? Do you practice in Bombay?
Yeah, I'm in Bombay.
No, do you practice though, or are you part of a palliative care team?
No, I'm a neurologist. But I do neuropalliative care in addition to my regular.
At Hinduja?
Yeah, at Hinduja.
Okay.
Okay.
Thank you so much, Dr.
Thank
Roop.
you, doctor.
Actually, we were
Bye.
very insistent to have you in the session. That is why we postponed the timing as well. And I believe that
Thank you so much.
was the right decision to make, because this is such a vibrant group and we wanted a veteran in the topic to be joining them.
Thank you.
To work us.
Thank you so much.
Thank you so much, Dr. Roop. And we do definitely look forward to having you in more of our such sessions. And with that note, this is Sri Priya along with Dr. Roop Gursahani signing off from the Tips Echo Hub. See you in the next session,
Thank you.
everyone, with another interesting
Bye.
topic and yet another eminent speaker. Till then, take care. Bye-bye.